I think while the slides are being set, I would just like to make a few comments about Dr. Sharma, who I was not involved professionally with, but with Dr. Urmil Sharma, of course, he's a professional colleague and a senior. Dr. Sharma was a very active member of all academic meetings and all social gatherings. And in fact, I was just mentioning to Dr. Urmil Sharma that even last year when I was giving a lecture here, same time, he was very much in the audience. He was always there for all meetings, and it's indeed sad that he's not with us today, but we'll try to do some justice to his memory by talking a little bit about obesity and diabetes. No, this is not Muslim. This is not Muslim. Excuse me a second, there's some glitch here. Talk today is really to emphasize the connection between obesity and diabetes, and this is particularly so because we see patients and families reacting every day about blood sugar being high, and now life has gone for a toss and everything has to change, and people do not seem to be concerned so much about the weight aspect, which actually is the precursor and a major deterrent to proper management of diabetes. So, when we talk of diabetes and vascular risk, we're talking of a whole conundrum of things, which includes obesity is one of the main targets for us. So when we talk of obesity and diabetes, you look at, of course, you all pretty well aware of the worldwide epidemic of diabetes, and you can see different colors here. This is the projection, this is the data from 2003, where the countries that are colored blue are the ones at risk, at higher risk, and the ones that are yellow are at the lowest risk, and in between are countries like India, Australia, and most of Latin America. But the projection for 2025, the colors change dramatically. The purple ones are the ones at the highest risk. The blue, India has entered the blue zone, which means 8 to 11%. And just to give you the current figures, it is thought that more than 50 million Indians are diabetic. It's also important to realize the overall prevalence of diabetes in India is roughly 7 to 8%. So it is not as huge as some people make it out to be. But this figure varies from villages to small towns to metros. And in the large cities of India, like Delhi or Chennai or Hyderabad, the prevalence of diabetes in adults is to the tune of 15-16%. And in the remote villages, wherever studies have been carried out, it is about 4%. So there is a major difference in the same gene pool, in the same people. So when people migrate from rural India to settle in larger cities, the prevalence of diabetes keeps going up. What is responsible for this increase in diabetes in India and worldwide? A lot of it has to do with our weight. Of course, again translates back into changes in lifestyle, sedentary habits, change in eating habits, but ultimately, a lot of the diabetes that we are seeing and that we are talking about is linked to overall increase in weight rather than any other thing. So, and therefore this term, which I am not particularly fond of, but has become popular amongst endocrinologists, is diabesity, which is diabetes plus obesity. And of course, you must have seen different versions of this slide, but this is my favorite version, the cover of The Economist in 2003, which shows the way that human development is going. And you can see how we evolved and where we are headed for with a glass of a cold drink, as we call a soda, in our hand, and maybe they should have thrown chips in the other. So that's the way we are headed. Now, the problem is not so simple. It's just easy to keep telling people that no, you shouldn't do this, shouldn't do that. It is a social problem. The way society has moved, the way things are marketed, the way we are pushing things to create an obesogenic environment, and that's the problem. See, it is not right to expect, for example, we hear this every day again, that somebody who's been diagnosed with diabetic, the whole family descends on that person. He shouldn't eat this, he shouldn't eat that, he's doing all the wrong things. But we make all the right things. The problem is that everyone is having wrong things. So if the whole family is having unhealthy food, that has to change rather than changing one person's diet because he or she has become diabetic. And that's a fundamental thing. So the whole environment. I did a talk show on Doordarshan recently, and the young Khalsa college students, and we kept talking about healthy food, and they asked me that where are the options? What do I get in my canteen? You say that you should have healthy food, you should have a heavy breakfast, and then have a lighter lunch and even lighter dinner, and the snacks should be healthy. Where are the snacks that are available that are healthy for us? So all the snacks available on the roadside stalls, in college canteens, in hospital cafeteria are often very unhealthy. So it's not about blaming an individual. We have to, of course, have self-will and discipline, but also we have to create an environment where health food is available all the time and promoted all the time, and rather than, as we say, marketing to everyone around. The kind of childhood obesity we are seeing now was unheard of a few years ago. Of course, this is a Western figure, but you can clearly see the same kind of thing is hitting our metros in a big way. In the US, 11 billion is spent yearly advertising convenience foods, snacks, and alcoholic beverages. We don't have numbers for India, but in terms of proportion of money spent on advertising for these things, it will not be significantly less than that. And the other thing that is important to remember is we tend to think, very often people come and tell me, oh, we are vegetarians, so, we have very healthy diets, we are vegetarian, we don't eat out. A lot of what we have in vegetarian diets is extremely unhealthy. And obesity and fruit and vegetable consumption, there's a direct correlation. But as a recent study showed, and I'm not going to give the details now, actual fruit and vegetable consumption in India is really low, considering a country which is predominantly vegetarian. Because what we count as vegetables are mostly potatoes and maybe onions or things like that. The actual vegetables that we talk about when we talk about healthy food is not affordable by people. So fruits and vegetables consumption is inversely related to obesity. You can see on this slide number of fruits and vegetables consumed per day, and you see the lower the fruits and vegetables, the higher the risk of obesity. So there is definitely a skewed distribution in this, and India is not a big consumer of fruits and vegetables. And we all know this very well about physical activity level. Again, from left to right, more obesity, the more sedentary you are. And obviously, less obesity, the more active you are. Which is proven by the fact the same gene pool that lives in the villages, when moves to the cities, everyone tends to become obese because of change in physical activity being one of the major factors. And in evolved societies, and as we are getting there in different ways, it's interesting. This is an American slide, which actually shows that level of education is inversely correlated, which means that more aware and more educated people are less obese. That is not really happening in India yet, except at the very upper end of the spectrum. Otherwise, the large Indian middle class, in terms of health and obesity, is like the somewhat lower socioeconomic class of Western countries, where food has become readily available, easy access to fast food, and we are all putting on weight. And it's only when everyone's education has reached a level when you're really aware of this, then you'll really be able to fight this. So in the West, the higher the education, the less the obesity, and that's how it is. What does obesity do? And today we'll talk about diabetes, gallbladder disease, hypertension, dyslipidemia, sleep apnea. You're aware of all these things. Coronary heart disease, osteoarthritis, cancer. A lot of correlation with cancer and obesity. Reproductive hormone abnormalities, we all see the number of polycystic ovary patients we see these days was not the case 30 years ago, definitely. Fertility issues, low backaches, so many angles. So everything, so many conditions that arise, which are called lifestyle disorders or chronic disorders, at the root of those is weight or obesity. And again, if you look at the relationship between diabetes and obesity, and I've tried to simplify this from various studies, mild obesity, 2-fold risk of diabetes, moderate obesity, 5-fold risk, and severe obesity, 10-fold risk of diabetes. And if you look at it very strictly, then roughly 90% of type 2 diabetes is attributable to excess weight. And actually, many studies have suggested by extrapolating data that at least 50% of type 2 diabetes will disappear if people are not overweight. So I think there is a strong connection that needs to be addressed rather than only tackling blood sugars as they arise. We leave this and mechanisms we leave for today. And we also, of course, know this is traditional apple versus pear-shaped obesity. And we know that central obesity, to which Indians are particularly vulnerable, is the one that actually makes you more prone to metabolic disorders like diabetes, whereas obesity that is centered around the hips is not as dangerous as obesity centered around the stomach, abdomen. And central abdominal obesity is the key, the bad fat that actually leads to all kinds of complications linked to obesity. And remember, because Indians have higher central obesity, we tend to get vascular and metabolic complications at lower weights. Therefore, the BMI cutoffs for Indians are different from those in the West, and anyone over 23 BMI here is considered overweight, and over 25 is considered obese. So that's really stringent criteria as compared to 25 and 30 that are seen in the West. Now, we'll analyze the body mass composition of 269 diabetics recently in our clinic, and if you look at the BMIs, and this is the changing face of diabetes in India. When we were students, many type 2 diabetics came to us as lean type 2 diabetes. Not unusual. Indians are not that obese, we get lean type 2 diabetes, that's the profile. If you look at, in a corporate setting at least, if you look at the mean BMI of 269 consecutive diabetics who underwent body mass composition as a part of their health check, 29 is the mean BMI, which is actually clearly obese, and it's even higher in women than in men, which is particularly disturbing. And I think our diabetes is becoming more and more like Western diabetes, where obesity is the main sort of role player. And if you look at this again, interesting slide, if you look at 18.5 to 22.9, the left two bars, and the blue bars are men and the red bars are women. If you look at that, only about 9% or less were actually, even in the men, were in 18 to 23, which is ideal body weight. Rest of them, almost all of them, were in the overweight or obese zone. And you can see even more than 50% of men and women were clearly in the obese zone by Indian standards. And here, the interesting part is that as age goes up, you find that the women become more and more obese. And the male obesity does not increase so much with age. It's there throughout, but in women, as age goes up, and of course, women have a higher proportion of body fat for the same body weight than men do. So those are major issues that we have found. And the other point that is important is that we can prevent diabetes to a large extent by lifestyle modifications. Losing just 5-10% of your body weight can make a difference. So do not set goals. I have seen prescriptions advised to lose 30 kg overweight. That is all nonsense. We should say, if you lose 10% of your body weight, that's your ultimate goal. So you start at 110, at least you should plan to lose 10 kg. Yes, if you're not in that zone, if you're wanting to reach lower or medical conditions require you, then you're a candidate for more serious things like interventions like bariatric surgery, because clearly some patients who are severely obese right at the start should be channeled into that direction. Dr. Kripalani is on the dais, where they actually undergo bariatric surgery, and really that makes a big difference to the outcomes. More and more data, convincing data, that bariatric surgery in severely obese patients with diabetes can have wonderful impact on their long-term outcomes. We leave that. So in terms of medication, can we do anything? Obesity medications have taken a beating. We all know about lifestyle. All obesity medicines come and go, and none of them stood the test of time because of side effects or lack of efficacy. Can we do something where we're talking of the twin epidemics of diabetes and obesity? Can we do something to address them both? Other than what I already said about lifestyle, diet, exercise, we're all aware of. Can some medicines help us? There is a lot of research in this area, because one of the big challenges is to have medication that will help you lose weight as well as control your blood glucose. And yes, of course, you know, metformin has been there forever, and metformin does promote weight loss to some extent. Unfortunately, metformin does not promote major weight loss, just a couple of kg, has many other benefits, and of course it controls your blood glucose. But there are also newer drugs like GLP-1 analogs, which act through the incretin pathway, the details of which I will not discuss, but it acts through a new pathway which promotes insulin secretion, acts on glucagon, and does various other things that not only controls blood glucose, but actually helps in losing weight. And there are multiple actions of this group of drugs. They have been around for a few years, and they have shown very promising and interesting results, both in the West and in our own hands in the management of diabetes and obesity. And one of the main actions of these drugs, of course, is to promote insulin secretion. They suppress glucagon, but they also affect the brain to reduce your energy intake. And they affect your gastric motility to reduce your appetite. And that's how, among other things, these drugs will help us. So if you look at the last few slides, where we're sharing the experience with one of these molecules, which is liraglutide, which is a currently hot sort of molecule amongst diabetologists and endocrinologists, which is given once a day and is a powerful molecule to reduce blood glucose. It's an injectable drug. Also helps significantly in weight loss. These are the first 100 patients of ours, or 108 actually, on liraglutide. We have close to 200 now. And you can see the maximum, the weight range is between 140 kg and 68.7 kg. So, and the BMI range is 27 to 53. Some of them should have straight away gone to Dr. Kripalani, but they don't agree for that very often. So we have to modify our techniques accordingly. So using these molecules, what have we done? It started with an injectable therapy of 0.6 milligram once a day, and then increased to 1.2. And most of them, our patients are on 1.2. Some can also be on 1.8 milligrams once a day. The adverse effects are significant. About 20 patients out of 108, that's roughly 20% or 18%, had anorexia, nausea, and abdominal discomfort. Most of the time, it is not enough to warrant withdrawal of drug and passes over a few weeks. So it is not a serious side effect, but in some patients, about 5% patients, you actually have to withdraw the medicine because of the anorexia, nausea, vomiting it produces. And the minimum weight loss was nothing. There were some patients didn't respond, but we achieved weight loss of up to 13 kilograms in some of our patients. And the mean weight loss was about 4 to 5 kilograms, which is commensurate with Western data. And there are all the benefits that accrue with the weight loss, obviously, are also seen in these patients. This is very short-term data. As these patients are follow-up, data indicates that they will continue to lose some weight even for up to 3 years of treatment. Obviously, when you lose weight and you improve insulin secretion, so the drug is doing both things. It is not a weight loss drug. It is an anti-diabetic drug which is also promoting weight loss. So we found a marked improvement in blood glucose, both fasting and postprandial. The average improvement was very significant, especially in the postprandial blood glucose, and a drop of more than 100 milligrams sometimes was seen in some patients in the postprandial glucose, and roughly 1% drop in A1C over a 4 to 6 month follow-up. So I think the idea here is that we have to connect in our minds. When patients get hung up on blood sugar, we have to explain to them that everyone is at risk who is overweight. And I tell my patients, they go and ask me, what should we eat? What should we eat? I say, whatever you make a single goal for yourself, you have to lose weight. We'll take care of your diabetes. Okay? We'll help you whatever you like with nutrition advice, with exercise advice, with behavioral therapy. In our center at Medanta, we've now introduced behavioral therapy for weight loss. So anything that is required for weight loss is what is appropriate for your diet. If you're able to lose weight, the same diet will apply for diabetes, and weight loss will help you clearly in controlling not just blood glucose, but reducing your risk for vascular disease in the long run. Thank you very much.